Take up Adkins versus the State of Idaho, case CV01-23-14744. We're convened for the sixth and apparently final day of the bench trial. In this case, we have at counsel table for the plaintiffs, Mr. McKay, Mr. Cabot, and Ms. Dady. For the defendant, Mr. Craig, Mr. Grigsby. We left off yesterday with the state having presented what seemed likely to be its final witness of its case in chief, and I'd like to confirm at this point, Mr. Craig, the state rests, or do you have additional evidence to present?
No, Your Honor. Just real quick, before I rest, I just renew the argument that Dr. Story, Dr. Hughes' testimony should be admitted as rebuttal evidence. I think we did show that under Rule 16D that there is good cause. Rule 16D requires that exhibit list be supplemented once additional exhibits are identified. We identified Dr. Story on Saturday. We disclosed him on the first business day afterwards on Monday. We identified Dr. Hughes on Monday. We identified him on Monday. There is good cause, and they should also be admitted to prevent injustice as the law requires. The plaintiffs are seeking to establish a new constitutional right here. I think it demands that the court hear all relevant and valid evidence in that case. And I think you heard testimony yesterday about the attacks that people who speak up in support of the unborn children get professional attacks over and over and over again. And so I think that provides the good cause, prevent injustice for us to have identified these witnesses. As soon as they were identified, provide them to the court. So just renew our argument that they should be admitted for all rebuttal purposes. Other than that, we will rest. Thank you.
Okay, understood. I'm going to adhere to the ruling I made yesterday on that topic. It doesn't appear to me that there was any material impediment to identifying these witnesses at an earlier stage of the case and disclosing them in timely fashion. I don't think there was good cause for the untimely disclosure, nor do I think that somehow the evidence must be considered for as rebuttal rather than impeachment in the interests of justice. So I'll continue to consider the testimony of those two witnesses only for whatever value it has as impeachment. So with that then, the state rests. I gather there will be some rebuttal case.
Yes, sir. We're prepared to proceed with our rebuttal case. Mr. Cabot will handle the first witness who will be appearing remotely.
All right, understood. Go ahead and call your witness.
Good morning, Your Honor. Nicholas Cabot for the plaintiffs, calling Jennifer Payne to the stand. Dr. Payne should be on the WebEx. Okay, that's fine.
All right, I understand we have some sort of technical difficulty, and so we'll take a recess while that's sorted out. We'll resume when it's ready to go.
All right. Yeah, she's on there. I'll get on her. Yeah, I'm just update it. Good morning, Dr. Payne.
Good morning.
Let's have Dr. Payne raise her right hand to be administered an oath.
Do you swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
Go ahead, Mr. Cabot.
Dr. Payne, would you please restate and spell your name for the record?
Sure. My name is Dr. Jennifer Payne, and that's Jennifer, and Payne is Payne.
I want to ask you some opinions made in court yesterday by the state's expert witness, Dr. Ingrid Skopp, on mental health, just limited to what she was talking about yesterday. I sent you a transcript of Dr. Skopp's testimony. Have you had a chance to review it?
I have. I've not necessarily read every word, but I skimmed it and focused on the discussion of mental health.
Do you have a response, and this is just a yes or no question, to some of Dr. Skopp's opinions as they relate to your expertise in reproductive psychiatry?
Yes.
I'd like to ask you about some of your responses. Dr. Skopp testified yesterday that patients with health or life-threatening conditions do not need abortion care because of the availability of alternative treatments. She identified two alternatives: inpatient hospitalization and electroconvulsive therapy, or ECT. At a high level, what is your response to the notion that abortion care isn't necessary because pregnant patients with severe psychiatric disorders can simply be hospitalized if they pose a threat to themselves?
Patients with psychiatric disorders can be hospitalized. However, that is not treatment in and of itself. And leaving a patient hospitalized without actively seeking psychiatric care, I think is unethical. And in addition, inpatient psychiatric hospitalization, while safer than being outside the hospital, does not preclude the ability of some patients to commit suicide.
And turning to that second option, at a high level, what is your response to Dr. Skopp's theory that abortion is never necessary because of the availability of ECT?
ECT is not indicated for all psychiatric disorders and not indicated for all severe psychiatric symptoms.
Did Dr. Skopp's testimony about the availability of other treatments for severe psychiatric disorders in pregnancy change any of your opinions in this case?
No.
Next, I'd like to ask you about Dr. Skopp's claim that abortion increases the likelihood of worse mental health outcomes, including anxiety, depression, suicide, and overdose. At a high level, what is your response to Dr. Skopp's claim?
I think if you review the entire literature in this area, it's very clear that well-controlled studies do not find an increase in adverse mental health conditions after abortion care.
What studies did you review?
I reviewed the National Academies work in this area. I reviewed the ATA task force work in this area. I've reviewed the turnaway studies. I think that there are a number of very well done studies that really support the idea that abortion care does not increase the risk of adverse mental health outcomes.
Dr. Skopp testified yesterday about those studies, and she acknowledged that the seminal literature, those studies, concludes that there is no connection between abortion and worse mental health outcomes, but she took issue with these studies. I want to quickly walk through the conclusions. Dr. Payne, I sent you copies of the seminal literature last night. Do you have that with you? Dr. Skopp,
I do. So I have printouts and I have the PDF.
Dr. Skopp testified yesterday about the APA task force report. Do you recall reading that testimony?
I do.
Compound mischaracterizes testimony. It's a very long lead up that was addressing multiple questions.
All right, just go ahead and restate your question.
Dr. Scott testified yesterday about the APA task force report. Do you recall that testimony?
I do.
Please turn to Exhibit 35, and this is tab 1 in the binder.
Okay,
Do you recognize Exhibit 35?
I do.
What is it?
It is the APA Task Force on Mental Health and Abortion. It is the report.
Is Exhibit 35 a reliable authority in the field of psychiatry?
It is.
Dr. Scott testified yesterday about that abortion leads to worse mental health outcomes. What does the APA task force report have to say about the link between abortion and adverse mental health outcomes?
That the literature really demonstrates that it is that there is not a link between abortion and adverse mental health outcomes. That the studies that found a link did not control for previous mental health conditions, and we know that women who have mental health conditions are more likely to seek abortion care.
Dr. Payne, would you please turn to page 2 of Exhibit 35?
Yes.
And would you just read starting with the first line on the first paragraph in the left-hand column?
And I'm sorry, by page 2, do you mean page 2 of the,
Oh, sorry, this is
or
page,
the base number?
Bates number 6, page 6.
That's what I thought. Okay. Okay. And then you said,
The first line of on the first paragraph on the left-hand column.
yes, the best scientific evidence published indicates that among adult women who have an unplanned pregnancy, the relative risk of mental health problems is no greater if they have a single elective first trimester abortion than if they deliver that pregnancy.
Your Honor, at this time, plaintiffs offer the statement from Exhibit 35.
Right. It's been read in the record without objection, so I would consider it part of the evidentiary record at this point.
Dr. Scott yesterday described the APA task force opinion as, quote, nuanced, because she claimed that for certain subgroups of women, there is an association between abortion and worse mental health outcomes. What is your response to that?
Again, I think you have to look at confounding and know that women who have mental health issues are more likely to seek abortion care. And it's the pre-existing mental health issues that then predict the following mental health issues after seeking abortion care.
Dr. Payne, let's turn to the next report that was mentioned during yesterday's testimony. Please turn to Exhibit 37, tab 2. And if you'd prefer to use the paper copies you have, that's fine.
I've got it here.
Do you recognize Exhibit 37?
I do.
And what is it?
This is a report from the National Academies on the safety and quality of abortion care in the United States. This was published in 2018.
What is the National Academies?
The National Academies is a very interesting group. They convene experts in various fields and on various topics and have them come together to assess the evidence for that particular topic and to identify areas of need for research.
How are you familiar with the National Academies?
I've served on 2 National Academies committees.
And what was the subject of those surveys and reports?
Women's mental health, broadly speaking.
Are the National Academies a reliable authority in the field of psychiatry?
Yes.
This is a consensus report. What is a National Academy's consensus report?
It means that the committee was tasked with discussing various issues about a topic, in this case, abortion care in the United States, and coming to a consensus about what the current level of data is on certain questions, and to identify areas for further research.
Did they look at the claim that abortion worsens mental health outcomes?
Yes.
Please turn to page, this is Bates, page 13 of Exhibit 37. What does the National Academy's consensus report have to say about the link between abortion and adverse mental health outcomes?
One moment. This is on page 13.
Yes, it should be page 10 of the underlying report.
Yes, okay. Mental health effects. It's under a section heading saying mental health effects. The committee identified a wide array of research on whether abortion increases women's risk of depression, anxiety, and/or post-traumatic stress disorder, and concludes that having an abortion does not increase a woman's risk of these mental health disorders.
Dr. Scott yesterday testified that the National Academy's report only examined a couple of studies. What is your response to that?
My response is that they reviewed a large number of studies in the 100s, I think around 150, 160. They concluded that 5 of them met their rigorous criteria for being included in the consensus report. It's not that they didn't review the others. The others were marred by various method problems or methodological issues.
Your Honor, at this time, plaintiffs offer Exhibit 37 under 803.18 for a good cause shown. A learned treatise may be entered into the record. We believe that it's not necessary to have Dr. Payne go through all of the methodological flaws identified in the excerpts that are part of Exhibit 37. And so at this time, we just move to have the whole exhibit, the excerpts that are part of the exhibit entered in the record.
Any objection?
We object on hearsay grounds.
All right. So what is that? You've had Dr. Payne read an excerpt, and then I guess what more do you need? What constitutes the good cause?
I think, Your Honor, that she was responding to Dr. Scott's criticisms of the National Academy's report and her claim that it only reviewed 5 studies, and it reviewed, as Dr. Payne just testified, around 100 studies, and that is documented in the excerpts that are part of the exhibit. And so going through all of that would not be efficient, but we think a response is sufficient if it's in the record, and we can certainly handle it to the extent necessary in our findings of fact and conclusions of law.
All right. Well, what portion of the document?
It would be
list the studies.
28 to 31.
Well, so it appears to me, just from a quick glance, that the first paragraph under the subheading mental health disorders on Bates 28 lists the studies that were considered. If that is right, then I think it would be preferable to deal with this by Dr. Payne or you reading into the record the first paragraph, which lists the studies considered.
Thank you, Your Honor. I'll read this into the record. The committee identified a wide array of research on mental health outcomes, including systematic reviews, Bellini and Bonocore, 2013, Charles et al., 2008.
All right, go ahead. Go ahead, Mr. Grigsby.
So we're objecting on hearsay grounds, and we're objecting that this mischaracterizes Dr. Scott's testimony.
All right, those objections are overruled. This is a portion of the publication established as a reliable authority by Dr. Payne's. Dr. Payne's testimony, it appears to come within the Rule 803.18 hearsay exception. I'll permit the completion of this reading of the paragraph. This is, I think, an alternative that avoids the need to reach the idea that there is good cause for bringing in the entire document. All right, you may continue.
Just one point on the Dr. Scott testimony part. My understanding is she did not indicate that they'd only reviewed 5 studies, but the conclusion was based on 5 studies. So that is what we're pointing to.
Your Honor, I can read verbatim from what Dr. Scott testified yesterday, and it was, you acknowledge the National Academy has accurately reported the data from the studies they rely on to support their conclusions. Answer, the limited studies, yes.
All right. Well, it's certainly in, I guess it's a response that to Dr. Scott's views on the number and caliber of the studies that support a view contrary to hers on the topic. It seems to me to be proper. You can continue or restart reading that particular paragraph.
I'll restart. The committee identified a wide array of research on mental health outcomes, including systematic reviews, Bellini and Bonecore, 2013, Charles et al., 2008, Coleman, 2011, Ferguson et al., 2013, Major et al., 2008, 2009, NCCMH, 2011, prospective cohort studies, Biggs et al., 2015, 2016, 2017, Foster et al., 2015, Monk Olson et al., 2011. Cohort studies, Ferguson et al., 2006, Gomez, 2018, Hurd et al., 2016, Peterson, 2007, 2008, Steinberg and Russo, 2008, Steinberg et al., 2011, Warren et al., 2010, and analyses linking medical record or registry data, Coleman et al., 2002, Kiesler et al., 2015, Lepelati et al., 2016, Monk Olson et al., 2011, Reardon et al., 2003. Most of the studies focused on whether abortion increases women's risk of depression, anxiety, and/or post-traumatic stress disorder, PTSD. With that, I'll move on. Why don't we turn to the next report that came up yesterday, the Turnaway study. Please turn to Exhibit 29, and this is tab 3 of the binder.
I've got it.
Do you recognize Exhibit 329?
I do.
What is it?
It is one of the reports from the Turnaway study, and it's titled Women's Mental Health and Well-Being 5 Years After Receiving or Being Denied an Abortion, a prospective longitudinal cohort study.
Is the Turnaway study considered a reliable authority in the field of psychiatry?
It is.
Could you briefly describe the Turnaway study?
So the Turnaway study was a direct response to the Surgeon General's request for a longitudinal study on whether abortion increases negative mental health outcomes. And essentially what they did was they took women who were close to the time of the cutoff in terms of being able to obtain an abortion, and compared those who met the cutoff and were able to get an abortion and those who did not meet the cutoff but had requested an abortion, and then compared outcomes over the course of 5 years for those two groups. And they did that because those two groups are likely to be extremely similar. They're both seeking abortion care. They're both close to the time of cutoff in terms of gestation in order to receive abortion care. And therefore, they have many more characteristics that are similar at the baseline of seeking abortion care.
Now, you said the Turnaway study was a longitudinal study. Did I understand that correctly?
Yes, sir.
In a few words, what is the scientific value of a longitudinal study?
A longitudinal study simply means that people are followed over the course of usually a period of time that can be years. And the value of that is that after an exposure, in this case, abortion care, you can have early effects from that exposure, and you can also have late effects. And so it allows you to see if there are acute effects of a particular exposure and long-term effects of that exposure.
Have you heard the term record linkage study?
I have.
In a few words, could you describe what a record linkage study is and your understanding of what a record linkage study is?
Yeah. So my understanding is that it links through insurance records, usually, a particular exposure, in this case, abortion care, to the later outcome of a particular condition. So insurance companies keep records of medical events. And so you can look to see if something like abortion care is associated with the later psychiatric hospitalization of that particular individual.
Dr. Scott claimed yesterday that record linkage studies are, quote, more high quality. When you're looking at cause and effect, how does a record linkage study compare to a longitudinal study?
It depends on the study, but in general, a longitudinal study is better able to look at the effects of a particular exposure, particularly if you've controlled the samples that you're recruiting from. So a record linking study doesn't take into account other factors that might confound the association between an exposure and a particular outcome. Whereas if you set a longitudinal study up correctly from the beginning, you can control for those confounding behaviors or characteristics that might influence the later outcome.
In your professional opinion, did the Turnaway study appropriately control for potential confounding factors?
They did. It's an excellent study.
Dr. Scott criticized the Turnaway study yesterday because she said it comprised, quote, a small group of 500 women. What is your response to that criticism?
The way this study was conducted, longitudinal studies are quite difficult to carry out. This particular study did a good job of limiting attrition. Yes, it's a small number, but it's really did a fantastic job of making sure that the baseline characteristics of the women who either received abortion care or did not were similar. And that really is a critical question in this area.
Dr. Scott also criticized the study because of its attrition rate. citing it as between 15 and 50%. What is your response to that critique?
So my understanding of the attrition is that it was approximately about 5% per year, which is simply outstanding in terms of doing a longitudinal study. And yes, the cumulative was larger over the course of the 5 years, but to achieve an attrition rate of 5% per year is really great.
Please turn to page 6 of Exhibit 329.
Okay.
And in the left-hand column, under the title Discussion, would you please read the second and third sentence?
Yes. Our findings add to the body of evidence rejecting the notion that abortion increases women's risk of experiencing adverse psychological outcomes. Women who had an abortion demonstrated more positive outcomes initially compared with women who were denied an abortion.
What does the Turnaway study say about the factors most strongly associated with experiencing adverse mental health outcomes after abortion?
My understanding is that they associate that with having a previous history of mental health conditions.
Would you please turn to page 9? This is the bottom of the second column, last sentence of the conclusion section.
Yes.
And would you just read that sentence?
Yes. These findings suggest that the effects of being denied an abortion may be more detrimental to women's psychological well-being than allowing women to obtain their wanted procedure.
In defense of her opinion, Dr. Scott testified yesterday that one of the articles she relied upon, a Ferguson study, is reliable partly because the author is pro-choice. Dr. Payne, if someone publishes a research paper with conclusions contrary to the author's personal beliefs, does that improve the article's reliability and credibility from a scientific perspective?
No, it does not. Good research is good research. And personal beliefs should not determine how you conduct a research study, nor how you interpret the results.
Thank you. Let's move on to a narrower topic from yesterday's testimony. Dr. Scott testified yesterday that abortion increases the likelihood of suicide. At a high level, what is your response?
Pre-existing mental health conditions increase the risk of seeking abortion care. And unless a study has controlled for pre-existing mental health conditions, it is difficult to conclude that abortion increases negative mental health outcomes and suicide.
Have you reviewed any literature on whether abortion increases suicide rates?
I have.
Please open Exhibit 402. This is tab 4 in the binder.
Yes. Okay. I've got it.
Dr. Payne, do you recognize Exhibit 402?
I do.
What is it?
It is a publication entitled Examining the Association Between First Abortion and First-Time Non-Fatal Suicide Attempts, a longitudinal study using Danish population registries.
Is this article a reliable authority in the field of psychiatry?
It is. It's done by an outstanding group of researchers.
And in your opinion, why is the Steinberg study reliable?
It's reliable because they control essentially for confounding by indication, meaning they control for factors that might influence the outcomes of suicide attempts.
Please turn to page 7 of Exhibit 402.
Okay.
And this is the last paragraph on the right-hand column. Do you see that?
So this particular version does not have columns. But
okay, you may have, there was a replaced exhibit. Do you happen to have a
Yes.
copy with you of the JAMA Psychiatry version? Okay, if you would please
I
turn
do.
to its Bates stamp 0007, or it's page 1037 of the actual journal article.
Yes,
Okay, and this has 2 columns?
it does.
Okay, great. So now turning to the last paragraph in the right-hand column, would you please read that paragraph?
Our findings do not support the notion that abortion causes or increases women's risk of suicide attempts. In fact, our findings support the conclusion that heightened suicide attempts are not caused by abortion, but by differences in other risk factors for suicide attempts. Consequently, policies based on the notion that abortion increases women's risk of suicide attempts are misinformed.
And I just want to go back for 1 second. I think we may have not identified the Turnaway study. So for the record, the Turnaway study is Exhibit 329. I'd like to turn to another topic, Dr. Payne. Dr. Scott testified yesterday that pregnant patients who receive lethal fetal diagnoses have improved psychological outcomes if they carry to term. What is your response to that?
My response is that has not been my clinical experience.
In your professional opinion, do you have any concerns about a law that forces a patient to carry to term after a lethal fetal diagnosis?
I do.
And what are your concerns?
My concerns are that every patient that I've managed who received a fatal diagnosis for their developing fetus decided to terminate almost immediately and spent a lot of time talking with me about the horror they felt about the idea of carrying to term, having to go to work, appearing pregnant, knowing that their baby would not make it. I think if those women had been forced to carry to term, that they would have really suffered from that.
Have you reviewed any research on this topic?
I have. There's very limited research on this topic.
Would you please turn back to Exhibit 35? This is tab 1, the task force report from the APA.
Yes.
Please turn to page 6. This is Bates stamp 6.
Yes.
And then the left-hand column, it's the second full paragraph. And would
Yes.
you please read that paragraph?
The few published studies that examined women's responses following an induced abortion due to fetal abnormality suggest that terminating wanted pregnancy late in pregnancy due to fetal abnormality appears to be associated with negative psychological reactions equivalent to those experienced by women who miscarry a wanted pregnancy or who experience a stillbirth or death of a newborn, but less than those who deliver a child with life-threatening abnormalities.
Dr. Payne, one final question to wrap up here. Even if someone were to accept Dr. Scott's criticisms and to believe that there is an association between abortion and worse mental health outcomes, is there any data to support the idea that there are worse mental health outcomes for patients who obtain an abortion because of a pregnancy complication?
Not to my knowledge.
Thank you, Dr. Payne. Nothing further. I pass the witness.
Mr. Cabot?
Thank you.
Cross-examination, Mr. Grigsby?
Just one moment, Your Honor.
That's fine.
No questions, Your Honor.
All right, thank you, Mr. Grigsby. Thank you for being here again, Dr. Payne.
Thank you. Take care.
All right, assuming plaintiffs have more rebuttal evidence to present, they may call their next witness.
It's called Catherine Winstrom, who will also appear via WebEx.
All right, the clerk is reporting that the witness is not present.
One moment, Your Honor. Apologize. Your Honor, she is here now.
Okay, I see the witness is here now. We'll wait just a moment. Okay, so we're not. It's not just something that you. Then that's fine. All right, ready to roll. All right, we'll have the witness raise her right hand and take an oath from the clerk.
Do you swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
Yes, I do.
Good morning, Dr. Winstrom. Can you hear me okay?
Yes, I can. Good morning.
Dr. Winstrom, do you understand this case to be focused on high-risk pregnancies?
Yes.
Were you listening to the testimony yesterday given by the defendant's expert, Dr. Ingrid Scott?
Yes, I was.
You were not here in the courtroom, correct?
That's right.
How were you listening to the testimony?
On the YouTube live stream.
Do you recall Dr. Scott's testimony yesterday that 85 to 90% of OBGYNs do not perform elective abortions?
Yes.
Do most OBGYNs provide pregnancy terminations for pregnancy complications?
Yes.
How often or how frequent is it for OBGYNs to provide those pregnancy terminations?
Well, they occur very commonly. So I think most practices would see many cases each year. I think it's hard to say exactly because we don't record them as abortions. You know, if a patient comes in with a much desired pregnancy and is informed that she has a complication so serious that we have to end the pregnancy, we do not go in the room and say, we're going to do an abortion. We try to speak as tactfully as possible, call it a pregnancy termination. We don't record it in the chart as an abortion. Usually we don't use the medical coding to describe our care as we don't code it as an abortion. So it's hard to know exactly how often this happens and how often this procedure is life-saving. But in my experience, well, certainly I'm a high-risk pregnancy doctor, so for me, this happened, unfortunately, probably once a week when I was on service. But I think the average generalist practice would see it many times each year.
I've seen calls for speculation, lack of foundation.
Response?
This is her opinion based on her experience and training. She trains, she's a professor who is involved in the training of physicians. This is well within her training experience to be able to opine on.
All right. I'll overrule the objection.
Did you hear testimony yesterday about D&Es?
Yes, I did.
When an MFM is determining whether termination should be offered or recommended to a pregnant patient, how does the method of termination factor into that decision?
It shouldn't factor into the decision at all. The decision of how to handle the pregnancy should be separate from the decision about what to do about the pregnancy, whether to terminate it or not, should be separate from the decision about how it's going to be terminated. So first we decide, must we end this pregnancy? And then after that decision is made, we would separately review the options with the patient and select the best method for this particular patient.
Based on your training and experience, if a patient with a high-risk pregnancy elects to have a termination, is D&E a better choice for some patients over induction?
Yeah, it could be, but it depends on the condition of the patient. So if the patient is sick enough that they have to be admitted to the hospital, if they're already infected, if they're bleeding, then that probably wouldn't be a choice. But if we catch the complication early enough and they're healthy enough, then a D&E would be an option.
And for some patients, is it a better option?
For some patients, it is.
And why would that be?
If you have to terminate a pregnancy in the hospital, it's generally by labor induction. The patient's on the same floor as patients laboring with viable pregnancies. It's unpleasant physically and emotionally stressful. D&E can be accomplished as an outpatient procedure in much less time. They go in, have the procedure, they come out, they can start their recovery right away.
Is the total abortion ban a ban on D&E abortion?
Objection calls for illegal conclusion.
I don't recall.
Hold on just a moment.
I can rephrase.
Let's do that.
Dr. Winstrom, you've reviewed the text of the total abortion ban, correct?
Yes.
And based on your understanding and your reading of the ban, do you understand it to ban D&E abortions?
I don't recall reading anything about D&E abortions in the ban.
I'm going to switch to a different topic. Do you recall Dr. Scopp's testimony yesterday suggesting that fetuses can feel pain as early as 15 weeks of gestation?
Yes.
In your opinion, does the medical community agree with that opinion?
No.
Can you explain?
Well, she gave as an example that during an amniocentesis in which she had a needle in the uterus in the amniotic cavity, if she touched the needle to the fetus would withdraw. That's a reflex response. The sensory fibers in whichever part of the baby, the fetus was touched by the needle, relays signals to the spine, and the spine immediately sends back a message to withdraw. So that's the same reflex we have if we touch a hot stove, we immediately move our hand. That doesn't even go through the brain where pain is perceived. In order to actually perceive pain, the sensory fibers have to deliver stimuli to the thalamus, which is sort of an egg-shaped area in the center of the brain, and then the thalamus relays the signals to the cortex, the thinking part of the brain, through thalamocortical fibers. Those fibers that connect the thalamus to the cortex don't develop before 24 weeks. So, and that's anatomically and physiologically correct. So before 24 weeks, the fetus cannot feel pain.
Dr. Scott testified that pain receptors attached to the midbrain around 15 weeks gestation. Is that enough for the fetus to experience pain?
Now, I think she's referring to the fact that the sensory fibers may reach the thalamus by that gestational age, but they don't relay that signal to the cortex where pain is perceived at that time.
Just one for the court. Thanks. Dr. Scott, do you have in front of you a copy of Plaintiff's Exhibit 290?
I'm Dr. Winstrom, and I can bring it up. It's on my computer.
I apologize, Dr. Winstrom.
It's okay.
And it's tab 2 in the binder.
So this is the ACOG document on pain?
Yes. Once you've opened it up, can you tell us what this document is?
It's an ACOG document titled Facts Are Important, Gestational Development and the Capacity for Pain.
Did you rely on this document in forming your opinions in this case?
Yes.
Could you read the second paragraph of this document, please?
The science conclusively establishes that a human fetus does not have the capacity to experience pain until after at least 24 to 25 weeks. Every major medical organization that has examined this issue and peer-reviewed studies on the matter have consistently reached the conclusion that abortion before this point does not result in the perception of pain in a fetus.
And can you also read the next paragraph?
Rigorous scientific studies have found that the connections necessary to transmit signals from peripheral sensory nerves to the brain, as well as the brain structures necessary to process those signals, do not develop until at or after 24 weeks of gestation. Because it lacks those connections and structures, a fetus or embryo does not have the physiologic capacity to perceive pain until at least this gestational age.
Thank you. Could you also pull up Plaintiff's Exhibit 291, which is tab 3 in the binder?
Okay.
What is this document?
It's a document from the Society for Maternal Fetal Medicine consult series called The Use of Analgesia and Anesthesia for Maternal Fetal Procedures.
Is this a document that you relied upon in forming your opinions in this case?
Yes.
Could you read from, so on the first page, the beginning of the very last paragraph that begins the experience of pain? Could you just read that paragraph, please?
The experience of pain, therefore, is dependent on an extensive developmental process. The components of the pain pathway develop at different times during gestation. The thalamocortical connections that carry stimuli, the sensory component of pain, to the cortex are present at about 25 weeks of gestation. However, although these connections are necessary, they are not sufficient for the perception of pain. Their mere presence does not indicate that a fetus at this gestational age is able to perceive tissue injury or other stimuli as painful.
Thank you. And could you also pull up Plaintiff's Exhibit 293, which is tab 4?
Yes.
And what is this document?
It's a document from the Royal College of Obstetricians and Gynecologists entitled Fetal Awareness, Review of Research and Recommendations for Practice, Report of a Working Party.
And what is the Royal College of Obstetricians and Gynecologists?
It's the National Society for OBGYNs in the British Isles.
And is that an organization whose publications are reliable in the field of obstetricians and gynecology?
Yes, they're comparable to ACOG, extremely reliable.
Could you turn to the page that says, page 8 at the bottom, the page says summary at the top, and let me know when you're there.
Okay.
Could you begin reading? I'm going to have you read most of the second paragraph. I'll tell you when to stop, but if you could begin reading that.
In reviewing the neuroanatomical and physiological evidence in the fetus, it was apparent that connections from the periphery to the cortex are not intact before 24 weeks of gestation. And as most neuroscientists believe that the cortex is necessary for pain perception, it can be concluded that the fetus cannot experience pain in any sense prior to this gestation. After 24 weeks, there is continuing development and elaboration of intracortical networks such that noxious stimuli in newborn preterm infants produce cortical responses. Such connections to the cortex are necessary for pain experience, but not sufficient, as experience of external stimuli requires consciousness. Furthermore, there is increasing evidence that the fetus never experiences a state of true wakefulness in utero and is kept by the presence of its chemical environment in a continuous sleep-like unconsciousness or sedation. This state can suppress. Okay.
Actually,
okay.
Go ahead and finish the paragraph. I apologize.
This state can suppress higher cortical activation in the presence of intrusive external stimuli. This observation highlights the important differences between fetal and neonatal life and the difficulties of extrapolating from observations made in newborn preterm infants to the fetus.
All right, thank you. I want to turn now to a topic of lethal fetal diagnoses. Do you recall Dr. Scopp's testimony that there is no diagnosis that is uniformly fatal at the time of delivery?
Yes, I do.
Is that true?
No.
All right. I want to spend just a little bit of time. We're not going to spend all day on this, I promise, but just a little bit of time walking through some diagnoses that are fatal at the time of delivery or before. And first, I'd like for you to touch on some skeletal diagnoses.
Well, the most common lethal skeletal diagnosis is called thanatophoric dysplasia. Thanatophoric means death-loving. It's a severe fetal dwarfing condition. All the bones in the arms and legs are extremely small, but most importantly, the chest does not develop, so the chest is too small to allow for lung development, which makes it lethal. They also have a very distinctive malformed skull.
How about asphyxiating thoracic dystrophy?
That's a similar condition. The fetal dwarfing isn't as severe as in thanatophoric dysplasia, but like that condition, they have an extremely small chest, which does not allow the lungs to develop and therefore is lethal.
And do you have a couple more examples of skeletal lethal conditions?
Sure. I think some people have heard of osteogenesis imperfecta, the fragile bone disease. There are actually 4 types, and type 3 is lethal because the bones are so fragile that most fetuses sustain fractures in utero. So even delivering a term, the fetus is already born with multiple fractures. The skull never calcifies, so the skull is membranous. If you put the ultrasound transducer down over the fetal head, the brain will compress because there's no skull to prevent that. The collagen defect that causes these problems also affects blood vessels, so they're very prone to rupture and bleeding, and this is just not compatible with life.
All right. How about achondrogenesis?
Achondrogenesis is another severe bony dystrophy that causes severe dwarfing conditions, and likewise prevents pulmonary development. There are actually several other lethal dwarfing conditions, so it takes some expertise to distinguish them. But once we've seen that the thoracic cavity is too small to accommodate lung growth, we can pretty much tell that it's lethal.
Could you describe cardiac lethal fetal conditions?
Well, we had one in this case, hypoplastic left heart. The left ventricle has to pump blood to the whole body, and if the left ventricle doesn't develop, it's too small, or it doesn't pump and therefore doesn't pump effectively, that is a lethal condition. The fetus, even if delivered at term, likely be too small to accommodate a heart transplant, even if that was possible, and also the arteries needed to hook up a new heart would be too small to accept the heart. So that is a lethal condition.
Could you describe some renal lethal fetal conditions?
Well, the worst one is renal agenesis, where the kidneys simply do not form. So we figure this out when someone comes in the second trimester and there's no amniotic fluid around the fetus. You cannot survive without kidneys. Even if you could somehow get a transplant without fluid around the baby, the lungs won't develop, so that makes it a lethal condition.
And
another one, oh, I'm sorry.
Go ahead.
Another one that involves renal problems is called Meckel-Gruber syndrome. Those kidneys are cystic. You can see the cysts on ultrasound. They're going to be non-functional. Those fetuses also have an encephalocele, meaning there's a hole in the back of the skull and brain is protruding out of the skull. And for reasons we don't understand, they often have extra fingers. That's actually an autosomal recessive condition, which means that each parent contributed an abnormal gene to this fetus and indicates that this could recur in 25% of future pregnancies.
And did you cover?
And then there's another.
Yeah, multicystic dysplastic kidneys.
Yeah, that's a different kind of kidney abnormality. The kidneys can be seen on ultrasound. They're there, but they're large and full of cysts. They fill up the abdominal cavity, and they are going to be non-functional at birth. So for the same reasons that the other two renal disorders are lethal, this is going to be lethal.
Could you provide some examples of neurologic lethal conditions?
Well, we've already talked about anencephaly at this trial, I believe. Lobar holoprosencephaly is a very severe condition. Normal brain development requires the brain tissue to split in half and to form two hemispheres, each with a ventricle or fluid-filled space in them. In holoprosencephaly, the brain doesn't split. There's abnormal brain tissue in a circle and a fluid-filled area in the center. So essentially, all of the brain development required for normal life does not occur.
How about fetal akinesia?
That's lethal.
Thank you. Fetal akinesia syndrome?
Akinesia means that the fetus doesn't move at all. We don't, in some cases, that's a general term. In some cases, it's neurologic. The nerves don't cause the muscles to move. In some cases, it's muscular. But without any fetal movement, the limbs don't develop and the lungs don't develop. So they are born with congenital contractures, and they don't respond to resuscitation because the lungs are not developed. That's lethal.
Could you briefly describe New-Laxova syndrome in EU?
That is a condition in which the brain doesn't grow, a very tiny abnormal brain. There's a very strange malformed face. They have very short limbs. They usually have severe cardiac defects and may also have encephalocele or defects of the spine. Because of the severely abnormal brain and neurologic development, that's lethal. That's also autosomal recessive, by the way.
Thank you. Could you briefly describe large encephalocele?
Well, I described encephalocele as having, kind of an opening in the skull with brain coming out. If that opening is large enough and a large portion of the brain is extruded from the skull during development, that brain's exposed to amniotic fluid. The blood supply to that area of the brain will be insufficient, and that area will likely suffer severe damage, meaning that the fetus will not survive after birth.
Could you briefly describe sacrococcygeal teratoma? I hope I said that correctly.
Yeah, a teratoma is an abnormal growth of fetal tissues. And in this case, it's a large mass with a lot of vascular supply originating near the sacrum. These masses can be so big that a vaginal delivery isn't possible, but when they're that big, the fetus usually doesn't survive because there's so much blood flow to the teratoma that the fetus is essentially in heart failure. So the fetal heart is pumping all its blood to the teratoma and not to its own tissues, and that is lethal.
I believe we've covered sacral agenesis, but just very briefly, could you describe that as well?
Yeah, it's a developmental field defect where the sacrum doesn't form. The nerves that would go down to the legs don't develop, so therefore the legs don't develop. And by field defect, I mean that other organs in that area of the sacrum, bladder, kidneys, genitalia, likely also will not develop. So without kidneys, normal bladder, and with a severely abnormal spine, those fetuses cannot survive.
And then finally, on the neurologic conditions, seronemelia.
That is a condition where the fetus, due to a vascular problem during early development, blood supply to the legs is compromised. And instead of developing and it's very early in development, instead of developing two legs, they develop one structure, sort of like a mermaid's tail, that doesn't function as a limb and also obstructs development of the bladder and kidneys. So that's also lethal.
Are there lethal fetal conditions that involve multiple different organ systems?
Yes.
Could you describe some of those?
Well, one of the worst ones is called limb body wall defect. Very, very early in pregnancy, the embryo has to fold, has to bend forward and fold from side to side. And if those folds don't occur, then the fetus ends up fused to the placenta. So the fetal abdominal wall is fused to the placenta. There's no umbilical cord. There's severe spine defects, severe scoliosis, and opening of the spine. They usually have abnormal brain development and cardiac defects as well. So they have basically a non-functional spine and a non-functional abdominal wall and neurologic issues, which means that's incompatible with life.
Could you briefly describe pentology of Cantrell?
So Cantrell described it, five defects that occur together: a very large abdominal wall defect, which means that the abdominal musculature didn't develop and all the internal organs are outside the fetal body, just covered by a membrane. A diaphragmatic hernia, meaning that the diaphragm, which separates the chest from the abdomen, has a huge hole in it. So any organs that aren't outside the front of the body are herniating into the chest, compressing the lungs so the lungs don't develop. There's also a severe cardiac defect. The sternum doesn't develop for some reason. And there usually is also a hole in the pericardial sac around the heart. So the heart's exposed to fluids from the rest of the body, and that is also a lethal defect.
And finally, hydrolethalis syndrome.
Yeah, hydrolethalis, lethal meaning lethal, and hydro meaning the brain essentially doesn't develop. There's just a rim of tissue, but and the fetus has hydrocephalus. So we may see some ventricles. In other words, there may be a septum down, a division down the middle of the brain. But the brain itself is just a thin rim around the skull, and the rest of the brain is filled with fluid. So there's basically absent brain tissue. They frequently have pulmonary hypoplasia, severe cardiac defects. Because the brain abnormality affects the development of the face, there's also cleft lip and palate. That combination of defects is not survivable.
Could you provide a couple of examples of lethal conditions involving abnormal twinning?
Well, these are all conditions of monozygotic twinning, meaning one egg is fertilized and then it splits. If it splits very late, after 2 weeks, then the fetuses may be connected in some way. If they're connected through their chest, they may share a heart. I had a patient whose fetuses shared a heart, and between them, they only had 5 chambers, and each heart required 4 chambers. So there would be no way to separate those without resulting in their death. If they're joined at the cranium, they may have brain tissue shared between the 2 fetuses, and likewise, there's no way to separate them without causing their death. So that would be lethal.
And then finally, a few chromosomal lethal fetal defects.
Well, we've talked about trisomy 18 as being lethal. There are actually 3 forms of trisomy 18. Classic trisomy 18, the fetus gets 3 copies of chromosome number 18 in every cell. There's partial trisomy 18, which means that there are 2 complete chromosome 18s, and then a large part of another copy of chromosome 18 has broken away from the chromosome and is translocated to some other chromosome. So you might have the long arm of chromosome 18 attached to chromosome 20, for example. And the presence of that gives a lot of the features of trisomy 18, and that is usually also lethal.
But can you explain why some fetuses with trisomy 18 survive after childbirth?
Well, partial trisomy 18, where you just have an extra copy of part of chromosome 18, may not result in the kind of serious life-threatening defects that are typical of trisomy 18. They may not have the severe cardiac defects, and they may have enough brain development, to support basic functions. But it's hard to predict that. If that is the case, we usually spend a lot of time doing ultrasound and trying to figure out what all the associated birth defects are going to be to determine whether that will be lethal or not. If the fetus doesn't have, those lethal or their severe organ defects, then they may survive, but they will still have the cognitive and developmental features of trisomy 18.
Can you tell prenatally whether the fetus has a classic form of trisomy 18?
Yes.
Could we briefly discuss trisomy 13, discuss what it is, and explain why some fetuses with trisomy 13 survive after childbirth?
Trisomy 13 is, again, due to inheriting a 3rd copy of chromosome 13 in every cell of the body. The brain is especially malformed. So they often have a form of holoprosencephaly, the condition I've already described, and will have severe facial defects as a result. They're born with extra fingers, which helps in identifying the syndrome prenatally. They have severe cardiac defects. Like trisomy 18, if they have only the 3rd copy of the chromosome is only a part of that 3rd chromosome is inherited, they may have less severe features than full trisomy 13. But even in that case, they generally don't survive very long because of the severe brain malformations.
Can you tell prenatally whether the fetus has a classic form of trisomy 13?
Yes.
Is trisomy 21 a lethal diagnosis?
Only in cases in which the fetus has the most severe form of the cardiac defect associated with Down syndrome. They don't all have cardiac defects, and some of them have a version of the cardiac defect which responds to surgery, but if they have the most severe form, then they may not survive.
And finally, triploidy. Is triploidy a lethal chromosomal defect?
Yes.
Is there another name for triploidy?
Partial mole.
And could you just briefly describe what that is?
in triploidy, the fetus inherits 3 copies of every single chromosome. So instead of having 46 chromosomes in every cell, they have 69. And so naturally, the malformations are severe, and this is not survivable.
You're aware, are you aware that Idaho's abortion bans allow termination for a molar pregnancy?
Yes.
Is it clear to you whether the exception for a molar pregnancy allows termination of a partial mole?
No, because those are 2 different diagnoses. So that is not clear to me.
Can you elaborate why they're different?
So a mole is a pregnancy in which the fetus has 46 chromosomes, but they all come from the father. So either 2 sperms penetrate an egg, and they lose the maternal component, or that's the most common way. So in that situation, placental tissue will develop, but there is no fetus. And the placental tissue is highly abnormal. So if you look at it with ultrasound, the uterus is filled with what looks like placental tissue containing multiple fluid-filled cysts. There's no fetus. So that it's obvious why you would need to terminate that pregnancy. If you don't, that can lead to a form of gestational neoplasia, but also it's clearly not going to result in a living child because there's no fetus involved. With triploidy, there is a fetus. The fetus is small, generally, and may have some birth defects, but it's a living fetus. The placenta will look abnormal, but not as abnormal as a molar pregnancy. So they're obviously distinct on ultrasound, and they're 2 really different situations.
Thank you.
In triploidy, you're faced with a pregnancy that has a living fetus.
Thank you. Dr. Skop, in her testimony, mentioned false positives in genetic tests. Do you agree with what she was saying about the rate of false positives in genetic tests?
Well, I think she was referring to the genetic screening test that all pregnant women are offered. So it's a screening test. You can have blood drawn, and the lab will tell you your risk or the likelihood that your fetus has trisomy 13, 18, 21, or chromosome or sex chromosome abnormality. But it's just a risk. It just will say your risk is increased or your risk is not increased. In order to determine if that you actually do have a fetus with one of those trisomies, you would have to have a diagnostic test. And diagnostic tests are absolutely accurate.
And finally, just turning to one last topic, Dr. Skop testified toward the end of her testimony yesterday that according to ACOG's practice bulletin on preeclampsia, ACOG doesn't consider the diagnosis of preeclampsia to be fitting unless the blood pressure elevations have occurred after 20 weeks gestation. Is that true?
No.
Could you,
No.
Could you elaborate on that?
Well, preeclampsia is identified when a patient without pre-existing hypertension develops high blood pressure during pregnancy, along with significant proteinuria and other laboratory abnormalities. If a patient comes in with a blood pressure of 140/90 or more and has proteinuria, she will be diagnosed with hypertension. ACOG specifies that at that blood pressure, the patient must be 20 weeks or more. However, if the patient comes in with severe blood pressure, 160/110 or more, there's no age limit on that. If 160/110 occurs with proteinuria, it doesn't matter what gestational age they are. We consider that severe preeclampsia.
Thank you. I'll pass the witness.
All right. Thank you. Mr. Craig, cross-examination?
Yes, Your Honor.
I suppose let me ask a follow-up to that. If you think you're in the ballpark of under 20 minutes, go forward. If you think you might take longer than that, which is fine, of course, we'll take a break first.
I think it'll be under 20 minutes. I don't mind taking a break right now if the court prefers to take a break.
I'd just as soon, just for Dr. Payne's, or Dr. Winstrom's sake, excuse me, finish her testimony.
Yes, Your Honor, thank you.
We'll keep calling her by the wrong name. All right.
I'll keep answering.
All right. Go ahead, Mr. Craig.
In fact, I think it'll probably be brief.
I thought it might. So.
Yes. Dr. Winstrom, you testified that you are able to determine with trisomies, and specifically trisomy 13, you are able to make a determination before birth as to what type of trisomy it is. So I want to read a portion of your transcript to you. Do you happen to have a copy of your transcript in front of you?
You mean my deposition transcript?
Yes, sorry. Thank you for that clarification. Your deposition transcript.
No, I don't, but I trust you to read it.
Okay. Your Honor, this is Exhibit 1031. So I'm going to read page 95, starting at line 14. So question, this was me questioning you. So is there a diagnosis of trisomy 13 that is not pure? And then your answer, well, you can't determine that until after birth. And then I'm going to skip ahead to page 97, starting line 17. Question, and you can't tell the difference between the 13 and 18, referring to trisomy 13 and 18 again, until after they are born. Is that right? Answer, no, 13, you can determine that by doing a genetic test. Question, I thought you said you could not tell if they are the mosaic until after they are born. Answer, oh, I thought you said tell the difference between 13 and 18. That we can tell, but we can't tell about a mosaic. That's all, Your Honors. Just wanted to read part of her transcript in.
All right, understood. That's the conclusion of your cross. Is that right?
Yes, Your Honor.
All right. Any redirect?
No, Your Honor.
Okay. So thank you again for being here, Dr. Winstrom. Will there be additional rebuttal witnesses?
No, sir, that concludes our rebuttal case.
All right. Thank you, Mr. McKay. Mr. Craig, will there be a sur-rebuttal presentation?
Yes, Your Honor. If we could take our break now, and then I think we'll be more efficient if we can do that.
That's perfectly fine. We'll take 15 minutes. Be in recess. All right, Mr. Craig, you may begin your sur-rebuttal case.
Thank you, Your Honor. I'd like to call.
Oh, I'm sorry, Mr. McKay.
Yes, please. If I may, Your Honor. Yeah, I'd like to raise an issue maybe in the form of previewing an issue that may arise during the presentation of the state's sur-rebuttal case. We anticipate they'll call Dr. Skopp as a sur-rebuttal witness. She's present in the courtroom. We are concerned that Dr. Skopp's testimony may stray into undisclosed opinion testimony. In response to discovery, we provided reports for Drs. Payne and Winstrom, and then when we received Dr. Skopp's expert disclosure, we provided rebuttal reports for both Drs. Winstrom and Payne, and we received no such rebuttal report from Dr. Skopp. And our concern is that she may now offer testimony that has not been disclosed. We know that, for example, with respect to Dr. Payne, I know from my colleague, Mr. Cabot, he conformed his examination on rebuttal of Dr. Payne closely to or completely in line with what was said in Dr. Payne's rebuttal report. And so I'm not sure what questions are going to be asked, but I wanted to raise that issue. We wanted to raise that issue at the outset of her testimony just because this might very well come up.
All right, understood. I guess I'm just going to observe that the scheduling order has a staggered expert disclosure schedule. Claimant effectively first, and then followed by a party defending a claim, which the state is, and then a rebuttal disclosure by the claimant. And those disclosures, coupled with any additional information elicited in deposing a party's experts, form the boundaries of permissible expert testimony. So I don't know what the questions are going to be, but it'll be. I do intend to limit expert testimony to the bounds of the disclosures. So
Very well, thank you, Your Honor.
all right, Mr. Craig, go ahead.
Yes, Your Honor. I'd like to call Dr. Ingrid Scott.
The whole truth and nothing but the truth.
I do.
Hello again, Dr. Scott.
Hello, good morning.
Go ahead, Mr. Craig.
Thank you, Your Honor. Dr. Scott, you were present for a testimony of Dr. Payne and Dr. Winstrom on rebuttal. Is that correct?
Yes.
And you heard their testimony criticizing some of your opinions?
Yes.
Okay, so let's talk about the fetal pain to start off with. You testified today that babies can feel fetal pain much earlier than 24 weeks in gestation, or you testified yesterday to that. Is that correct?
Yes.
And what do you base that opinion on?
Objection, Your Honor. For the reasons that Mr. McKay disclosed, that there was no sur-rebuttal disclosure in response to Dr. Winstrom's rebuttal disclosure. And so these were all topics that were disclosed. There was nothing in the sur-rebuttal filed, so we don't believe this is proper sur-rebuttal. But there was no disclosure of this.
Your Honor, this was mentioned in Dr. Scott's earlier report that was provided. She formed opinions on fetal pain. She provided her opinion on fetal pain. She testified about that today. They've attacked her testimony. Now she is entitled to, on sur-rebuttal, to support that. I think their objections are improper, and ask the court to allow me to continue with the questioning.
All right. It is a topic which Dr. Scott testified previously. It just seems like a back and forth on a topic where Dr. Scott made a disclosure. Is that not right? Was there no disclosure on this topic? Because there was testimony on it yesterday.
There was a disclosure on fetal pain. She did disclose her opinion on fetal pain in her report.
The question asked her to provide the bases for that opinion, which I imagine were gone into yesterday. That's my recollection. But it's a topic on which a disclosure was made. So that doesn't seem to this doesn't seem to be off limits. It's a question of whether we get to the point of this is supposed to be a funnel where the issues narrow as we go through iterations or rounds of testimony. If we get to the point where Dr. Scott is either straying from disclosed testimony or just repeating things she's already said, then we're done. But until we get to that point, I don't think we are done. So,
Your Honor, if I could be heard briefly.
fine.
Dr. Scott put fetal pain in her report, in her disclosures. We provided rebuttal to that. The sur-rebuttal testimony should be limited to new matters. Walker versus Disler, the 78 Idaho 38 sur-rebuttal is supposed to be responding to new matters. And as you said, Your Honor, the funneling is not going to happen if we're just going to keep calling witnesses back and forth. This is not a new matter. This is something that was disclosed. It was responded to. She had every opportunity yesterday to disclose all of her, the bases on which she was relying for fetal pain.
Okay. Objections overruled. You can answer the question.
Thank you, Your Honor. Dr. Scott, Dr. Winstrom referred to several studies in her rebuttal testimony. Do you recall that?
Yes.
Are you familiar with a study published by a Dr. Bridget Thill in the year 2022?
Yes, I am.
And was that a peer-reviewed article?
It was.
And is it of the type of articles that experts in your field rely on in forming your opinion?
Yes.
And do you know Dr. Thill, or Till? I don't know how to pronounce it. I apologize.
I do know her, yes.
And do you consider her to be a good researcher?
I do.
And you rely on her opinions?
I do.
Okay. And you have in front of you that article, is that correct?
Yes, it is.
And that's fetal pain in the first trimester, is that correct?
Yes.
And it was published in 2022?
Yes.
And that is after many of the studies that Dr. Winstrom was relying on in her testimony on rebuttal, is that correct?
That is correct.
Could you please read for us the abstract starting with the second sentence to the end of that?
Objection, Your Honor. I don't believe, unless I'm mistaken, I don't believe that this article was disclosed in Dr. Scott's report.
The opinion was disclosed. You don't have to disclose every single article that may exist that's out there. This is well within the bounds of what she reported and is directly rebuttal of Dr. Winstrom's testimony.
All right. Well, I'm going to reserve ruling on the objection and permit the reading.
Thank you. Go ahead.
Thank you. Current neuroscientific evidence indicates the possibility of fetal pain perception during the first trimester, less than 14 weeks gestation. Evidence for this conclusion is based on the following findings. Number one, the neural pathways for pain perception via the cortical subplate are present as early as 12 weeks gestation and via the thalamus as early as 7 to 8 weeks gestation. Number two, the cortex is not necessary for pain to be experienced. Number three, consciousness is mediated by subcortical structures such as the thalamus and the brainstem, which begin to develop during the first trimester. Number four, the neurochemicals in utero do not cause fetal unconsciousness. And number five, the use of fetal analgesia suppresses the hormonal, physiologic, and behavioral responses to pain avoiding the potential for both short and long-term sequelae. As the medical evidence has shifted in acknowledging fetal pain perception prior to viability, there has been a gradual change in the fetal pain debate, from disputing the existence of fetal pain to debating the significance of fetal pain. The presence of fetal pain creates tension in the practice of medicine with respect to beneficence and non-maleficence.
There's one word in there that many of us probably don't understand what it means. Sequelae, what is that?
Sequelae would be subsequent outcomes, usually adverse.
Dr. Skop, you were present during Dr. Winstrom's testimony about lethal fetal diagnosis this morning. Is that correct?
Yes, I was.
I'd like to read for you from the rough daily transcript of your testimony yesterday and then ask you some follow-up questions. So the question for you yesterday was, let's talk about lethal fetal diagnosis. Are you familiar with that term or similar type terms?
Yes.
Sorry, I'm still reading, so and Your Honor, just to clarify, this is page 144 of the transcript from yesterday. Okay, and then your answer from yesterday was, I'm familiar with the term. The current preference is to call these life-limiting fetal diagnosis because we recognize that there's no diagnosis that is uniformly fatal at the time of delivery. So that was your testimony yesterday. There's no fetal diagnosis that is uniformly fatal at the time of delivery. What did you mean by that, at the time of delivery?
Objection, Your Honor. Again, this is more redirect. He had an opportunity to ask about this yesterday. This is not proper sur-rebuttal.
Overruled. You can answer.
Thank you. So during a pregnancy, the mother's circulation, the mother's systems protect the baby. So the mother's circulation sends the blood flow throughout the baby, disposes of waste products through the mother's system. Now, some of the tragic situations that Dr. Winstrom discussed earlier do result in very medically fragile babies. And some of these babies do die in utero and are stillborn. However, many of those conditions affect systems that the baby does not require during pregnancy because the mother's body is performing that function for them. So any of these can result in a child that is born alive, recognizing that many of these conditions are so serious that the child may die shortly after birth from inability to perfuse or circulate blood or whatever the abnormality is. But none of them is uniformly going to result in the death of the baby before the chance at birth. Each of these can result in a live birth, even if it's a very limited life afterwards.
Thank you. I don't have any other questions.
All right. Thank you, Mr. Craig. Any cross-examination?
Yes, Your Honor. Good morning, Dr. Skop.
Good morning.
Do you have the Bridget Thill article or Till article in front of you still?
I do.
This is an article that was published in the Catholic Medical Association, is that correct?
The journal is called the Lineker Quarterly.
And that is, but at the top of this, it states Catholic Medical Association?
Yes, they are the organization that publishes this peer-reviewed journal.
And in the right-hand column of the first page, it states estimates for the onset of fetal pain perception over the past 20 years range from the first trimester, and for that, it cites AA plug. Is that correct?
Yes.
And then it says that it ranges, other estimates range until some point after birth. And for that, it cites RCOG, the Royal College of Obstetricians and Gynecologists. Is that correct?
That is correct.
And on page 2, in the second column, it states in the U.S., the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine state that fetal pain is not structurally possible until at least 24 to 25 weeks gestation, that the fetus cannot be conscious of pain until the third trimester at the earliest, and cannot perceive pain as such until late in the third trimester. Did I read that correctly?
Yes, you did.
You've never published a peer-reviewed article on fetal pain, is that correct?
No, I have not.
Never taught on the subject?
No.
Never done any work with the International Association for the Study of Pain?
No.
Any knowledge you have on the topic of fetal pain comes from having read some literature on the topic and observing in your clinical practice what you characterize as a pain response from an unborn baby, correct?
That is correct.
You, Dr. Scott, do not consider yourself an expert on fetal pain.
Not based on the criteria that you just gave, publishing on it.
You are not a maternal fetal medicine specialist?
I object. We went through all this yesterday.
All right. That question was asked and answered yesterday.
If you have a patient who you believe may have what you've termed as a life-limiting diagnosis, would you call in an MFM to continue the care for that patient?
Yes, I generally do.
Nothing further.
All right. Thank you, Mr. Herron. Any redirect, Mr. Craig?
No, Your Honor, thank you.
All right. Thank you, Dr. Scott. You may
Thank
sit
you.
down. Any further sur-rebuttal evidence, Mr. Craig?
No, Your Honor, thank you.
All right. It would seem we are at the point where the evidentiary record has closed.
But one moment, Your Honor. I would like to renew our motion to dismiss under Rule 41B2 that we filed for all the reasons that we have in our written brief.
Okay, that's perfectly fine, and I'm going to deny the motion, and we'll render a ruling in an orderly way that'll take the form of findings of fact and conclusions of law that address the claims made and whether and to what extent they were proved. We'll need a protocol for doing that. I had suggested yesterday that I thought it was likely counsel would want to obtain a trial transcript before being required to come forward with their proposed findings and conclusions. Counsel do want to do that, is that right?
Yes, we do.
All right. So it's kind of customary for parties to split the cost of the transcript. I suppose I don't need to get in the middle of that necessarily. But is that how folks see that playing out?
We're agreeable to that.
That is fine, Your Honor.
All right. And what I would normally do is set a deadline for proposed findings and conclusions that is some number of days or weeks after the transcript is delivered. If we proceed along those lines, how much time do you want to do that?
Our proposal, Your Honor, is that there be simultaneous submissions by the parties 6 weeks after the transcript is completed.
All right, how's that sound, Mr. Craig?
That's agreeable to the state.
I'm fine with that as well. 6 weeks after the transcript is delivered, the parties will simultaneously submit proposed findings and conclusions. Now, do you want, before the matter is formally under advisement, an opportunity for a further written submission that I guess essentially responds in some fashion to the opponent's proposed findings and conclusions? I haven't normally done that, but it's a bit of a different situation than some other cases. So I'm open to the idea. I'm not suggesting that I'm not suggesting a preference of mine one way or the other on it.
We don't believe it necessary, Your Honor.
Okay.
That is fine as well, Your Honor.
All right, that's fine. The parties are ordering a transcript. They'll split the cost. The court reporter will prepare and deliver it from that point. The parties will have 6 weeks to submit their proposed findings and conclusions. At that point, the matter will be under advisement, and a decision in writing will enter in due course. Anything else?
Not from us, Your Honor. Thank you.
All right. Thank you all. We'll be in recess.
Just to clarify, Your Honor, I may have jumped the gun on renewing our motion to dismiss before evidence was officially closed. I will renew it after evidence is officially closed.
All right, understood. Same ruling. It's really, I think, not feasible for me to render a ruling with which I am as comfortable as I can be in terms of its propriety, its accuracy, until I've seen the parties' full-on written proposed findings and conclusions. All right, we'll be in recess.
All rise.